Well, welcome everyone. Welcome to this Digital Medicine Society webinar. Today, as you can see, we'll be talking about the state of the virtual care industry. And I know you're here to hear from this incredible group of panelists. Have an easy job today because they are absolute experts in this field. And if you are familiar with DIME, you know that one of the things that we pride ourselves in is bringing together cross-industry stakeholders to work on the big problems in the industry. And so this is such a great example of that. So in this webinar, I'm going to start off with some housekeeping items for y'all. This is a webinar, and we will be recording the webinar, which means if you're on live, you get a chance to ask questions live, and we'll get to those. And if you're listening to the recording, you should be able to find any links and other resources on our website shortly after this is recorded. So other housekeeping, let's see. You can ask questions during the presentation. You can ask questions by typing them into the Q&A box. And we will get to those as they pop up potentially, or at the end. And at the end of the presentation, we've reserved some time for live Q&A. You can either, again, type your question in or come off mute and ask your questions live. And I would absolutely take advantage of this opportunity if you can, because we have, again, such great panelists. Let's see, what else? Oh, yes, my team is going to be dropping links into the chat of any resources that are relevant to this, this discussion. And there's some really great data out there. Of course, we can only just touch on the data, but lots of supportive. All right, so to dive right in, I'd like to begin by making some introductions. Advance this slide here. All right, so if you're not familiar with the Digital Medicine Society, DIME exists as a nonprofit, and we're dedicated to advancing equitable, effective, ethical, and safe use of digital products to optimize human health. So I'm Lynette Demers. I lead a program called Impact that is hosted or co-hosted by DIME and the American Telemed Association. And our mission is within this, under this umbrella, is to advance the virtual first care industry. So again, keeping with that idea of equitable, ethical, effective, and safe, we now are looking at the virtual first care industry as a collaborative group, and you can see all the logos here, trying to understand what are the biggest problems that, that we need to solve in, oops. I'm watching the screen advance here. Okay, what are the biggest problems that we need to address in the industry? Move on here. All right, so that's my introduction. And today we're talking about the results of a survey on the state of the virtual and virtual first care industry. It's a survey of employers and payers. And I thought that it'd be really interesting, if you haven't already seen the report, definitely download it. I thought it'd be great to have stakeholders from across the industry that represent different perspectives come and talk about both how the findings are reflected in their own experience from their perspective, but also maybe anything that was surprising or really compelling to them. So I'm going to start off with Arvind Stokes from Omada Health. And actually, before I let you introduce yourself, Arvind, I want to put a huge shout out to Omada Health team that really drove this survey. We and Rock Health, I say influenced and supported the creation of the tool and some of the analysis at the end, but Omada really did the bulk of the heavy lifting, and kudos to you for doing that for the industry. So Arvind, can you introduce yourself and give us a sense for some of the impetus behind the survey and how it sort of works in how you use this in your work?
Yeah, thanks, Lynette. Can you hear me okay? Just a quick audio check.
Absolutely, yes.
All right, virtual first world, it's got to make sure that you're not on mute or anything silly like that when you start out. So yeah, thanks for you and Dime for hosting us today. And my name is Arvind Stokes, and for the past 5 years, I've been Vice President of Customer Success and Client Operations at Omada Health. For those of you that don't know Omada, we are a virtual first chronic care provider, helping members make lasting changes to improve health and also reduce care costs for organizations. Our integrated care programs help people make lasting behavior changes that really improve their lives. And so really excited today and being around people who are revolutionary and forward thinkers in virtual care. It's just a privilege to be here with Meg, Megan, and Kate and team. So thank you so much for letting me be here.
Awesome, thank you. And thank you for being here. I'm so glad that you guys are here. Meg Barron, do you want to go next?
Sure, happy to. And thanks so much for having me. I'm Meg Barron. I lead digital health strategy and innovation for American Medical Association. So at the highest level, we're focused on how do we help to make technology an asset and not one more thing or one additional burden for patients and physicians and care team members across the industry. And at the highest level, we're really focused on how do we help to improve the quality of digital health technologies and solutions, including those that are virtual first, as well as, and on the other side of the coin, how do we help to get optimal scale, adoption, and really optimization? And what we really focus on at this point is digitally enabled care. And that means moving beyond just in-person and virtual kind of coexisting, but more so figuring out how do we best really get these two worlds to bridge and be as integrated and coordinated as possible for optimal patient care. So thanks for having me.
I love that. That's sort of the future of virtual is hybrid, and the future of healthcare is digitally enabled. It has to be. I love that. Thank you. Kate Brown, you want to go next?
Yeah, hi everyone. Thanks so much for having me. I'm Kate Brown. I'm a partner with Mercer and I lead our Center for Health Innovation. For those of you who might not be familiar with Mercer, we are an HR consulting firm, and one of our biggest lines of business is consulting to employers on designing their health and benefit strategies. So as we think about virtual care and virtual first care and how the employer plays a role in the adoption and access to those solutions, they're a pretty big stakeholder group that doesn't necessarily always have a seat at the table. So really excited to be a part of this conversation today.
And I'm glad you're here. You keep us honest from that buyer side. All right, Megan Zweig.
Yeah, thanks, Lynette. It's great to be here with you all. I'm Megan Zweig. I'm COO at Rock Health. We exist to make healthcare massively better through the use of emerging technologies. We do that in a few different ways. One is through Rock Health Capital. We're investing in early stage startups in digital health, including Omada. We work on Rock Health Advisory. So we're advising the large scale healthcare enterprises on their innovation strategies. And then finally, through rockhealth.org, our nonprofit, we're really trying to look at the adoption of these solutions through the lens of equity and thinking about supporting equity-centered design as well as supporting underrepresented founders. Super excited to be a part of this conversation because it touches all of those pieces of who do we invest in, what does investment look like right now, how are enterprises thinking about adoption and partnership on these solutions and what's disruptive to them, honestly, and then how do we do that with equity at the center to make sure that we're building for and reaching all and closing some of those disparities that we see.
Brilliant. Yes, and I love that you can also reflect on I'm going to say sort of the experience of the health system incumbent in a way, right? So
absolutely.
And any examples you can give us of like who's really doing this well, who's partnering with innovators and driving it versus, sort of the thing that when you work in the innovation space, you often look at them as sort of the dinosaurs, but there are some incredible examples, right, of collaborations and innovation, and we need to know about them. All right, so let's jump into it. Let's see here. Get my next slide. Come on here, advance. There we go. Okay, so why are we here today? So about almost a year ago, Rock Health, Dime, and Omada Health decided that this field of virtual care is growing so quickly. The impetus, of course, was the pandemic sort of exploded things. I'm not sharing my screen. Okay, share screen. Let's come back to this. Presenter view, share. Somebody give me a thumbs up. Am I sharing the right thing? All right. Okay, so we decided, this is before my time, we decided that we really need to get a handle on we had a sense for massive amounts of telemedicine adoption because of the pandemic, the sense for, consumers and patients and even physicians starting to get comfortable with this. But we really didn't have a good sense for how do the buyers, both payers as well as self-insured employers and others, making decisions about what type of care is going to be best for their members and patients. And so we really wanted to set a benchmarking or a baseline of where are we today, what are the perceptions, and how acquainted are our buyers with the innovative models that we all, probably a lot of you on this line, have been talking about in our own bubbles. Is this really going to be mainstream? How much awareness is there out there? And then that should give us some insight going forward when we repeat this survey of where are we really hitting the mark, what do buyers really need, and how we can create that all the way from early stage investments all the way through the implementation, because of course we can have the best company in the world on paper, but it's the execution, and we're learning so much about how to partner with our buyers now, rather than throwing a dossier over the fence. That's much more of a collaboration. All right, so this survey just released. You can find it on Omada's website as well as on our website. And some of the top line takeaways we're going to talk about today, and we're going to talk about what each of us from our different perspectives really finds compelling or insightful. So you probably read the screen by now. This is a great survey, like almost 800 senior leaders. And these are folks that are really hard to get to talk to you, right? Unless you're at Mercer. It's hard to get employers to spend the time, and it was a very comprehensive survey. So you can see we got a range of both size and plan type, self-insured, as well as covered employers. So really a very nice cross-section. And if you haven't looked at this survey, I definitely download it. And you should be able to find the link in the chat function. So we started off in the impact group, the group that I lead within Dime. And one of the first things we did was try to define as a group, what is virtual first care? What is not telemedicine, but this new idea of, as Meg said, digitally enabled healthcare that is a complete redesign of healthcare. And so the survey was really meant to probe how much awareness in the buyer group is there for this idea or model of virtual first care. And of course, since people hadn't really heard of virtual first care, we had to dance around various definitions. But we really anchored a lot of the questions around these principles that you can read on this slide. But the idea that we started off really trying to probe is how much awareness is there of virtual care in general, but also this idea of initiating care anytime, intentional selection of site of care. So not parallel, but an integrated hybrid network, adherence to laws, this is real healthcare, and then complete solutions. So not just an app, so that's what we started off with. And, I think we expected to see that people hadn't heard of it but they wanted it. And largely that's what we found. So takeaways here. So if you look at the survey, this is one of the big takeaways we had. So as you might guess, there's a lot of, again, a self-reported survey. A lot of people reported that, yes, they're doing telemedicine. They had to. Yes, we have lots of experience with coaching, both on the employer and the health plan side. But when we started to ask about how excited are you about the opportunity for virtual care to transform healthcare for your members, that was very much on the fence. And we had to really try to unpack that. So we think that it's because there's still quite a blurred understanding of what we mean by virtual care. And that nice definition that we put together in our bubble has not yet made it to mainstream. I'd like to ask Kate to kick us off on this. And because we've talked a lot about the employer side, from your perspective, there really is a lot of confusion about definitions. And so let's take a little bit of time on this definition thing.
Yeah, I think what I've seen, Lynette, and I would be curious to hear if the other panelists are experiencing this in their respective realms also. But in the employer and in the consultant space, I think that the terms telemedicine, virtual care, virtual first care, all of them are kind of used interchangeably. So there's definitely an opportunity for us as an industry to get crisper about what are the definitions of each, where are there potential overlap, where are they discrete topics that are definitely separate things. And I do think that this report starts to attempt to do that, as does the V1C definition that the impact group put forward. So the pieces are out there. I think we just have to do a better job really educating the market on what we mean by each of these terms. And words have meaning, right? So we need to be, I think, judicious about how we use them. The reason that that matters so much, and this is where it starts to get interesting with these findings, is that, okay, if you equate telemedicine with virtual care or virtual first care, yeah, everybody's experienced telemedicine. 90% of employers have it in their benefit plans. It's very common. But if you think telemedicine is virtual first care, of course, you're not going to think that it's going to drastically change or revolutionize how healthcare is delivered, right? Because the experience of telemed, and nothing against that, it certainly serves a purpose, but it in itself is not that exciting, right? It doesn't inspire a bunch of thought about the potential future for virtual care. And so that's what my interpretation is of this like big drop off of like, yeah, we know what telemedicine is, but it's probably not that exciting. But curious for what others think.
Yeah, happy to jump in, Kate. One of the things I've seen, and my background, I come from the startup world, and startups or emerging markets always feel this pressure to use this lovely buzzword, which is just to disrupt things. And so during COVID, you had so many new, entry points for programs and solutions, and everyone's trying to figure out a way to educate the space, coming out with all these different terminology that's new. And telemedicine became such a buzzword that people that had to adopt it didn't even get a chance to catch up. They were trying to survive COVID. They were trying to learn about all these different players that were coming at them and trying to redefine different jargon. And so one of the key differentiating points I think that's critical, that I've heard all of the panelists actually be strong advocates for quite some time, is the sense of telemedicine trying to replace and disrupt in-person care. And coming from Omada and some of the things that we believe in our core that virtual first care needs to do is actually empower a lot of the in-person care as part of an ecosystem that needs to get better. Everyone talks about this in the political landscape about healthcare needing to change, but specifically what needs to change is how we bring information together, how we leverage all the new flexible and technology holistically to really treat people in a manner which they deserve and share information, so that we can have more real-time treatment and personalized treatment. And so, that was one of my big learnings, actually looking at the study myself, is that differentiating point and that education that we're responsible for doing. And especially a lot of the thought leaders like you, Kate, and Meg and Megan, and people that need to really trust and listen to those visionary leaders about how that separates, so we get the right solution to the right companies, buyers, consultants, so on and so forth.
Yeah, I have a literal sticky note in my report that was like, more work to do for the consultants and industry.
And Meg, can you talk about, as you're talking, Arvind, I was like, wow, physicians are recognizing this too. It's like the biggest growth areas in the report that you guys just put out on the physician side were help me manage my patients remotely better. Give me, tell us about that report.
Yeah, so as a little bit of background, since 2016, when I joined the group, we wanted to do some initial baseline research to get a real pulse check on what physicians nationally were using today in 2016 in practice. And this was already assuming, of course, they were using electronic health records to varying degrees of, pleasure or frustration for that. But this was more focused on telehealth, remote patient monitoring, clinical decision support tools, et cetera. And what we were wanting to dig into is current usage, enthusiasm for use, and then key requirements for adoption. We've repeated that research as a baseline in 2019, and actually those results came out a month before COVID hit. So it was interesting to already start to see, an increase in use in things like telehealth and remote patient monitoring. But now we just repeated the results in 2022. So as suspected, of course, we all know, telehealth tripled in usage, and that over half of physicians in the country used it for the first time during the pandemic. But one of the key things I think is really interesting is that enthusiasm is really high for telehealth. And if you take electronic health records as an analog, when that was kind of forced upon people, from even a change management standpoint, oftentimes the end user gets lost in translation from that, be it the, physician, care team member, or patient. But I think what's seen in the reverse, because of the 7 different solution categories that we ask about routinely in this, telehealth has the highest jump in enthusiasm for physicians, in addition to the highest usage jump, like across the board. So I think that's really telling, right? That people see the potential, physicians see the potential. They want the autonomy to be able to make the case for the right care, the right time, the right modality of care based on the use case and the environmental variables of both their practice setting and the patient's, just setting in general as well, because the goal is really increase patient access, of course, increase clinical outcomes. Of course, people want to see return on financial outcomes. And you also need to think about the patient, physician, caregiver, care team member satisfaction scores for all of this too. And I can speak more about that in a minute, Lynette, just about our return on health value framework. But I think the other quick thing about our digital health research is the key drivers that we're seeing in terms of the need or want to continue adopting technologies such as, virtual care, remote patient monitoring, et cetera, is the ability for these technologies and tools to, of course, help them provide better care. And we did see this year an increase in the advantage that physicians say, and again, these are physicians of all practice settings, all different specialties, age ranges, et cetera. We saw a definite increase in those that said, yes, this is helping me have an advantage to provide patient care if integrated correctly, right? But I think that integration piece is critical, because when you've got this sea of point solutions, I think at times that's what's holding us back. If you don't have a proper zoomed out view of the problem statement or problem statements, right, within a setting or within a health system, and to be able to help to connect those dots. So I'll stop there, but I think the good news is the enthusiasm there, the intent to want to continue to adopt and leverage these tools and technologies is absolutely there. I think the need to ensure that reimbursement can continue, and the need to ensure that from a workflow integration component and just basic change management 101 standpoint, that those are as coordinated as possible. And that really gets back to that North Star goal of digitally enabled care, right? And that's what truly can be transformational in nature versus these two things just coexisting and hoping that, right, that mix or secret sauce happens to happen, which we know if we're not deliberate about, it won't.
Yeah, I think that's a good point, or a good time to move on to my second takeaway. To your point, my gosh, we've moved so far past, telemed or async care for, urgent conditions, kind of a jumped up triage. And we talk a lot about primary care. But if you look at this slide on what buyers are offering, it's a lot of, I don't say they're not necessarily point solutions, but they're starting to cover a lot of ground, specialty care, chronic care, as well as more transactional care. And I thought, gosh, this is this was really eye-opening to me, because when I go to AHIP and talk to them, it's still surprising to them that that virtual first care or virtual care can be effective outside of, the sort of more medical conditions, or seeing less medical conditions, things like smoking, mental health, et cetera. And so this was a surprise. So I thought maybe, Megan, if you could sort of comment, because you have such a perspective all the way from like what you're investing in, what you see investments in, sort of a little bit of a supply side push, and where do you see things going, and any other reflections you have on this sort of point solution world that we're moving into, or hopefully.
Yeah, I totally was very much agreeing, like head nodding with Meg's point about point solutions being kind of being a challenge to adoption, being a challenge to buyers. I do think that the proliferation of them, though, means that we have a lot of great teams working on narrow problems, and that can be a good thing for the ecosystem, that they're narrowly focused, they're building solutions with a particular end user in mind, with a particular condition or issue in mind. And I think that focus can bring about really, really great solutions. Will those solutions then probably be rolled up into something broader and bigger? Yes. And we're absolutely seeing a lot of consolidation, especially when you think about broader market indicators of funding slowing down, of valuations slowing down a bit, especially in relation to the year that we had last year. Like the time is ripe for greater consolidation in this space. The other thing I was thinking about, kind of sparked by the last slide, was, when we think about the definition of telemedicine, I would say at Rock Health, yes, still absolutely excited about kind of virtual first care models, but also thinking beyond care models that explicitly use exclusively the clinicians that we've been relying on in the past. So what I mean by that is we've actually been really excited by models that we're seeing where they're engaging people like peer coaches. So not clinicians, but peer coaches to support people with substance use disorder, peer coaches to support young women as they're going through lifestyle changes. We've also seen models where you're taking one-on-one therapy and turning that into group therapy. And you're actually attracting people that otherwise might not have access to or be able to afford one-on-one therapy, but might actually be more comfortable with this accessible option where there's a group and there is a therapist kind of shepherding that group. I think that what those examples get at is, traditional telemedicine is still really costly and it's still not particularly scalable. And so what are those kind of care models that unlock both of those two things, right? Greater cost effectiveness, greater scalability, because I think that's what's going to ultimately create accessibility for broader populations. And it's certainly, affordability, scalability are certainly things that employers and other buyers are thinking about.
And I love that you brought up this sort of not just unlocking scale, but unlocking different types of expertise. And, a long time ago, there was some work over in England about the sort of patient experts. And this was before we had any digital technology, but recognizing that in some fields like diabetes, the health behaviors are follow like viral type models, infectious models and healthy behaviors. And so I'm unlocking different types of expertise so that our limited supply of, MD trained, such that can be working on those medical problems, but different types of expertise. Yeah, we've been, I guess on the side, but thinking about like, how do we pay for all this? Meg, you brought that up. Like when we start to shift from that one-on-one, physician, patient, 30 minutes, 60 minutes, 90 minutes, whatever it is, to team-based care, different types of providers, async, synchronous, we really need to start not just thinking about, what are the codes, but how are we really redesigning those workflows? I love the work that the AMA has been doing to map those. Kate, we talked about like point solutions and in the impact group, like where are the integrators, or talk a little bit about this consolidation. How are employers managing all these solutions? Like, what do you see as a solution to that?
Yeah, so I think the term that's been used is point solution fatigue. You probably heard that before, and I would say that's fairly reflective of how many employers feel these days. Maybe not necessarily because they've implemented a ton of different vendors themselves, but it could be point solution fatigue in the sense that they get inundated with outreach from point solutions just day in, day out. And by extension, their consultants do as well. And I think that there's a demand from the employer groups that they need help understanding what virtual first solutions make the most sense, which ones add the most value. To Megan's point, which one creates the greatest cost efficiency, the greatest access. And I don't know that there's a silver bullet for that, Lynette. I know it's some work that the Impact Group is about to take on in 2023, where we're looking to see what are the keys of value and how do you communicate that to buyers. I think that's very important work, but I don't think it's been solved for just yet. The other thing that I wanted to mention, going off of Megan's point about affordability. So we just did some research within Mercer. It's a report called Inside Employees' Minds. I think they're going to pop it into the chat. But it was basically a survey of about 4,000 US-based employees. And there were a bunch of concerns that came up to the top of the list, and financial security was among the top concerns for employees right now, which is not really surprising. But one of the things that I guess gave me pause was that within the results, 68% of people indicated that they have a hard time affording healthcare for themselves and for their families. That's a huge issue, right? And I think that that's one where virtual care has the potential to help address some of that affordability challenge that we see. And so that's what kind of keeps me optimistic about this space. And particularly as we think about sort of the point solution approach and the different conditions that could be touched. Again, if you've got a chronic condition, but you feel like you have an affordability issue, if there is a specific solution that your employer is granting access to that allows you to manage that condition without significant out-of-pocket cost, that's a really impactful solution that, matters to both employers and employees.
I love that. And we've had some conversations in the impact group about, there's the public health emergency flexibilities, even around, 0% copay for preventive med. And, some of that's at risk. And gosh, if you're a policymaker, listen up, right? Because this is really important stuff. So yeah, the pandemic's been an interesting experiment, in a way. Yeah, go ahead.
One thing I wanted to add on to this like affordability conversation is, we're talking about the healthcare system being broken, and like an instinct to that is like, we need more care, we need more interventions, we need, more kind of surveillance of people in their home, monitoring, et cetera. But it's like, who's going to do all that, right? Providers are already incredibly burned out. There's a shortage. And so I think there's this important piece of like pairing the intervention with technologies that are going to make the workload easier. So a good example of that is like, we worked with a company called Marigold, invested in them, where they're using NLP, so natural language processing, to kind of understand the sentiment of some of the chats that peer coaches and patients are having. So that NLP can flag if, someone is sharing something like suicidal ideation, or if they just seen a tone shift in how that person is showing up in that group, so that then they can escalate that to the appropriate clinician or care manager who can intervene at the right time. So that means that care manager doesn't have to call all of those patients every day. They can actually rely on the technology to signal to them when that proactive outreach is going to have the biggest impact and is needed. And Arvind, like what I know about Omada's model has always really impressed me, because it's not just leveraging people like health coaches, but also really leveraging analytics to understand what is actually driving behavior change and outcomes. So you can actually temper the amount of communication, the amount of intervention that you're doing with any single person, so that it's truly personalized and you're not kind of over leveraging a resource that isn't getting you either the economic outcome or the patient outcome that you need. So I think that kind of layer of analytics and technology is super, super important to get to affordability and better support providers.
Yeah, that scale piece. I almost think that, we ought to look at our V1C definition again, because when I talk to the impact members and folks in the community, it's intentional selection of site of care. It's also intentional use of technology to triage and escalate in a way that like load balances and gets patients to the right level of care, the right time in a very personalized way. So AI, ML tools, other ways. I mean, we can't just do one-on-one like the old model. We need to be able to use these tools. That's how we get the scale.
One thing I would add, because I couldn't agree more, and what we've seen results get continuously validated from our baseline digital health research, is related to the key requirements that physicians have on behalf of their patients for adoption, which seem like no-brainers, but a lot harder said than done, right? And they really fall into 4 key areas around proved me it works and has an evidence base, right? And I think that's where the Omadas of the world have done a really great job. Then prove to me that there's a fair payment pathway for this. And if I use this or prescribe this, that again, that reimbursement piece is going to be able to be there, because it just is somewhat of a necessity. And then the liability piece. And I think this is where, when we talk about emerging technologies, be it honestly, even remote patient monitoring at this point in time, because of the 7 different solution categories we asked about, RPM was still the least utilized of the 7 solution categories. And that largely falls into the change management aspects of getting chief compliance officers and chief financial officers kind of bought in. But also, we've got a huge hurdle still that a lot of those technologies or tools don't integrate into the EHR. The validity of some of the data that's coming back at times, this gets into another requirements piece, that liability, right? Who's liable for that? Like if those readings aren't accurate or correct. So I think we're just brushing the surface of the potential for things like remote patient monitoring to be able to get additionally leveraged, but we need kind of some table stakes, quote unquote, like criteria. AMA, we with American Heart Association and others have something called a validated device listing, because I'll give you an example. It's my dad sitting at my coffee table, taking his blood pressure, writing results on the back of a receipt, right, with a blood pressure device that's probably 12 years old. I'm like, oh my gosh, this poor provider or physician on the other end of this, like these aren't even actionable insights or results. So I think that's kind of the more pragmatic components that we have to think through. And that plays into the last kind of key requirement, which is the workflow piece. And how do we get these things better aligned and coordinated?
Yeah,
And
Linda,
I think new equity issues too, right?
Absolutely.
So if you have a panel of patients, how many of those patients are going to be able to use a connected device?
That's right.
You know, do they have Wi-Fi? Do they have
Absolutely.
yeah, one thing I was going to say again, great points from Meg and Megan. I'm so in love with this space. I don't come from healthcare prior to the last 5 years, even though my parents are physicians and kind of my heroes and got me into this space to truly help what they needed help with. But I love all the healthcare warriors. There are so many people where I come from in different spaces that kind of work against each other. And I saw some great questions in the chat about like user adoption rates and within each chronic care. And I'm shocked when people don't share all the information out there, when you're not doing great work and not leveraging people like Kate, consultants who have just incredible experience and see the gamut of what's out there, and Megan, all the research that's happening at AMA and incredible VCs like Rock Health that are trying to really help other companies do things. And so, part of the precipice with this survey is to give people a taste of what's happening out there and to challenge them to go out and ask questions. Because if you're not sharing all the information and the data and trying to find benchmarks and the clinical rigor are all wrapped around that, to partner with your buyers, to partner with your consultants, to partner with the VCs to try and figure out how to make things better, instead of doing what happens in most spaces that come in new with so many incumbents and also so many new players. It saturates. People then become very archaic. They don't really change anything. I look at it like streaming providers. I'm getting now advertisements on my streaming providers. The costs are going up. I feel like we're going back to where television was, and that can't happen in this space. I didn't get into it. I know no one on this panel got into it just to be a decent or good company. And if we don't share that information right up front and have the data rigor and the clinical rigor first and foremost, even if you're going to be virtual, then you're not going to do anything. You're just going to be a same fragmented, broken system. And I think, I heard Megan mention something about this as well, that's irresponsible. And so plus one to everyone talking about and mentioning a lot of the data. And I hope that people that are joining today don't just look at the survey and think that, that's it. That should be a spark and a catalyst to say, reach out to these panelists, help shape what we need to do better. Because Kate and Megan are people that work with people like Sean Duffy at our company and Lucia to make us better. We know we have a lot of work to do, and we want to make sure that we're doing it in the right direction. So appreciate all that focus on the data and the clinical rigor.
And the impact group too, just a plug for, I literally have the best job in the world because I get to call on you folks and bring you together. So, okay, to your point, people got into healthcare because they want to make things better. When you ask a bunch of employers who are responsible for keeping their employee health costs down about ROI, we expected in this survey, I'm say ROI, you got to have a return on investment. And any economist would say, anyone who says they don't want a return on investment isn't long for their job. But if you look at this slide's been up for a while, so everyone's seen it, but there was a pretty significant majority that said, yeah, ROI is important, but we want more than that. We want solutions that can meet our employees' needs. And if you look into the report, you can see some of those. But we really thought there was and of course, a bunch of people that are responsible for taking care of their populations. That's very heartening to see that they're really trying to think about an expanded ROI. And I wanted to give Meg Barron a chance to really say, like, how are we thinking about, when I think of an expanded view of ROI, I immediately, as an economist, think of, well, what are the value drivers then? What are we measuring? What do we need to account for? And all of you out there, the developers, our providers, what do we need to prove when we come to the table? And it's an impact project that's just launched, but I know you guys have done a ton of work at the AMA. So
no, it's the $4 trillion question, right? Like, how do you make improvements based on some of this? And this is something, because we're having constant conversations with practices, small private practices, very, very large health systems that are value-based care, health systems that are still fee for service, large payers, large employers, right? Everyone's wrestling with this. And that's why we created, and I think you put it in the chat already, what we've termed this return on health virtual care, but it's honestly broader than that, value framework. So where you really need to think of it as almost just classic innovator's dilemma of, like, can I afford to do this? Can I afford not to do this? And I think most are in that second bucket of recognizing that, of course, we need to, again, move towards digitally enabled care in a world where we're better, coordinating these two worlds. But then there's just the pragmatic aspects of, you need to keep the lights on too, right? And margins are super slim. Everyone's in this kind of inflation like mindset. When you've got health systems, again, that have really, really slim margins, when you're trying to make the case for additional investment in virtual, right, or new technologies, sometimes you need a way to be able to show a longer, bigger, zoomed out view of how outcomes are getting created already. We've done that in a way to where we created a value framework to look at what a practice or health system's environmental variables are. So again, what's your patient population? Are you fee for service? Are you value-based care, et cetera? And then created some buckets of ways to quantify how outcomes are getting generated. ROI, or financial ROI, is of course a component of that and needs to be. But then back to, how are clinical outcomes getting created? Of course, sometimes that can be a longer tail as well to be able to look at. But we've got case studies from all over the country, be it from the Oshners of the world to small private practices, of them being able to prove outcomes are being improved if XYZ is done, right? Same goes for health equity, same goes for patient access, same goes for caregiver, patient, and physician satisfaction, right? Like, improving. And again, it's difficult. And we've had a lot of conversations with specialty societies, because a lot of this can be kind of specialty or use case specific. What we're attempting to do next to kind of build on this return on health research is two things. One, we've been having discussions with the specialties to start almost breaking down what are those top use cases where, again, a true blend of virtual and in-person is really yielding the largest results, and how can we work backwards to really start to create some best practices that employers, payers, et cetera, can also kind of integrate into the investments that they're making. The other is a report that we put out at HLTH conference just a few weeks ago that folks like Megan from Rock Health and 40 other contributors were a part of, inclusive of large employers, payers, VCs, health systems, et cetera, as well as physician perspectives of those that are working in kind of traditional brick and mortar settings, and those that have chosen to go work for more digitally enabled companies to get those different views. Because what we're recognizing is there's this kind of digital health disconnect of sorts, and that we need more best practices, or almost a case study showcase of sorts, right? Inclusive of some of these return on health kind of outputs or additional best practices, to be able to elevate that. And then again, to start almost creating a library of, here's what's working, because that's what I'm on the receiving end every single day of, just tell me what works. And we want to do that, right? And in lieu of that, or in lieu of right now, an app store that has outcomes totally integrated into it and like a funnel, right? Like based on those outcomes that's getting constantly updated. I think that's where we need to start, and that we need to be super open to kind of sharing friction points and sharing best practices that are being seen across these key stakeholder groups. And that's the call to action we have in that report, because I think AMA, we can help be a pre-competitive kind of space to be able to convene around that topic.
I love that so much, because if our medical specialties get together and define these are some best practices, these are this is clinically great care, here are some of the tools, then we can start to say, okay, what are the workflows for integration in hybrid systems? What payment models might we need, right? So you and I, Meg, we talked about how we can start to map these best practices and see where is coding falling short now? Where do we need to map that? So so much coming together in that. I flipped to our next, or our last takeaway, and there's a lot of comments coming in on the chat, and I want to open it up to the group to ask questions. But I thought sort of our last talking point could be really, where are we seeing the really bright spots, those best practices, those, whether it's Kate, employers that you work with that just nailed it, or ones that are not getting it. Arvind, some of the folks that you work with at Omada that are really great partners, and why. So I put this slide up here. What does it say? When we did a subgroup analysis of the data, because there's a lot of data in there, we can start to see that there are personas that emerge of respondents, and there's a visionary, we call the visionary persona, that tends towards a lot of awareness and a lot of enthusiasm and adoption for services and offerings that are aligned with what we call virtual first care. Okay, that's good. And then we looked at, okay, what are their priorities? What's important to them in buying? And these are you can read the data yourself, but patient engagement. They really want patients to be active participants. And the at first blush, that's great, but how do you translate engagement into outcomes? And what are the right measures of value? They really want better integration of patient information across providers. So, okay, so who's doing this well? Who wants to go? Arvind, you're unmuted.
Happy to. First, just a little more on the way Omada thinks, not only just in the survey, but the pleasure they have with working with what we call these visionary buyers. So first and foremost, they have a deep understanding of virtual care beyond telemedicine and telehealth. And they believe, like Kate, Megan, it must be invested in now and in the future. Second, they are early adopters, not afraid to invest in new ways to attack problems, to get involved in testing new programs, and to learn. Third, they collaborate with vendor partners to help shape the actual products and technology. And I mentioned this earlier, where if you give a lot of vulnerability in terms of the data that you share and you partner with these incredible buyers, they are helping you try to get to an incredible member experience for their population. And to that point, fourth, they have a clear vision for how virtual care can positively impact their population experience, setting high bars with product adoption, program experience, and outcomes. And then last, they have a really smart criteria, and I'm assuming people like Kate are really helping them with this, on revolutionary care delivery models when selecting virtual care partners. And some of them that I'll just mention today: Boeing, Costco, American Eagle. And since we are using their technology, I'd be remiss if I didn't call out Zoom as well. They really fit into this criteria and deserve a shout out, because they believed in virtual care before COVID. You can see that they are setting the pace in many ways with how they shape the space. And we're just really grateful to partner with people like that push us to be at our best and continue to learn and grow.
Mm-hmm.
Yeah, and I just want to emphasize the point that Arvind made around those buyers that are willing to partner and to build with their vendor partners, because here we are, we're having this conversation about virtual care, virtual first care, and it's very clear that the space is evolving very quickly and that it's relatively new. It's a new concept to a lot of people. And so I think that's the biggest thing about these visionary buyers who are first movers in the space, is that they're also willing to get their hands dirty and recognize that the partners haven't figured it all out either. So they're not just buying something off the shelf, they're buying something that they believe in and then working with those partners to actually execute on it.
Mm-hmm. Now, you guys would love this. So one of the projects we just launched is value and evidence. I think, Kate, you're part of that group. And I said, just as a straw man, well, what about a model value dossier? And the group was like, no, that's a static document. The way that we need to work with our payers and employers is collaborative. We need a playbook for how do you start? How do you collaboratively get the data, work on implementation, and literally be a learning system? And that's the aha for me for this group, is that there's no longer throw it over the fence. There's not a dossier, it's a collaboration playbook. And I heard, some really great examples. So first in New York, or other partners that work with Medicaid populations, they roll up their sleeves and it is a weekly data exchange and you implement together. And again, case studies of what works, Meg, you have to show people how to do it. We really need to, I think, applaud the people that are stepping in first, because it's never cost effective to be first, right? Do it because so any other comments on so like, who can we learn from, and how do we find these people, these visionaries, and learn from them?
Well, and the one thing additional that I would add, and again, always open to feedback and ideas for this, because it's always a toggle between, case studies. One can say, well, that's just applicable to you as an N of one, right? Well, of course, there's shared learnings and insights, and sometimes an 80-20 rule that can be taken from that. But that's what we need to additionally kind of scale and be able to, again, showcase, in my opinion, and stop repeating where we're seeing kind of breakdowns, right? Like across the industry. Again, we found that the case study kind of component of this has been really effective, and us helping to nationally kind of amplify that through different stakeholder groups and channels. We, specific to practices and health systems, have something called an immersion program, where we allow people to just connect with their peers. And to Lynette, to your point, I mean, we found that to be incredibly effective, because people, are at varying degrees, and it's a classic meet people where they are, right? From like an educational standpoint of like, give me the like snapshot view, and then I want to be able to go to someone who's lived or has lived experiences with this to ask them questions. But lastly, would be remiss, for the future of health research we just put out. That's why we've kind of termed it around a blueprint for the industry to move towards digitally enabled care, because we fully recognize that there's customization needed, and that everyone's got kind of their secret sauce of the way that they're going to want to do things, and just natural kind of competitions like across healthcare and the industry. That said, where there are, opportunities for just those shared best practices, we just have to do a better job of that right now, or we're really doing a disservice to the industry, let alone for digital health. And Megan touched on this, when consolidation is additionally inevitable. I mean, we have to be able to see those with an evidence base and those with true outcomes kind of rising to the top.
Yeah. So I actually, Meg, where do we find those case studies? Maybe our team.
Yeah, so we've got enough. So if you were to, I can put it in the chat, in the Q&A.
Oh, that'd be helpful. Yeah.
But in the immersion program, so all of this is mission driven and freely available. So we've got our immersion program. So if you put in AMA immersion program, you're going to be able to see a whole library of different case studies. In our return on health research, there's a number of both real world case studies and illustrative case studies that we extracted from aggregate data and qualitative interviews that we did. And then for future of health, we've got some case studies in there as well, from the likes of One Medical and how, they're approaching digitally enabled care, and Mayo, and they've got an OB Nest program, right, that they've rolled out, and all. So there's some other pockets of case studies in there too.
That's really helpful. And if you are working in the virtual first care space, we're another source to help you get the word out. So get a hold of us. We'll write up a case study, and it's more of a, quickly sharing to the both on our Slack channel, but also on our website. There is so much work to do in the pre-competitive space that you keep your secret sauce, but we really need to get this going. I'd love to open up for questions. There's a couple questions in the Q&A, and if Andrew Matskin wants to kick us off. Andrew, there you go. You had some comments and the questions. Go ahead.
Thanks, Lynette. Hi, everybody. I was curious about the ROI data because, Lynette, I think you said that you found that surprising, and I certainly did too. And it made me think that a number of the respondents, I think this comment was made at the outset, were answering these questions maybe with a mental model around telehealth rather than virtual first care and solutions that provide alternative access rather than supplementary care, as is the case with chronic condition management from Omada and Duo and others, which is additional, but hopefully still positive ROI. And I think if you're in that world, as I am day to day, ROI is quite a bit more important than the data on that slide suggested. So I'm just curious for the moderators to hear your perspective on that. And maybe the question is how important you're seeing ROI be across different types of both telehealth and virtual first care type offerings.
I'll jump in. I think you're right. It probably does vary like vertical by vertical where employers expect to see hard dollar ROI versus a softer VOI metric. And I think that those spaces that have more of that robust clinical data and more of those financial outcomes and have been around longer probably have a higher burden of proof than some of the more niche or newer verticals that have emerged as like conditions that an employer could put a solution in place for. But I do think that, that the point that ROI may not be the most important metric, if we looked at the number 3 finding that Lynette had there, that doesn't necessarily surprise me. I think that a lot of employers recognize that there are other assessments of value that matter, particularly in a time right now where the labor market is so tight and they have that pressure to both attract and retain talent. If they have to spend money to do that, it's just a kind of a reality of the labor market right now. And so I think that could maybe be influencing some of those responses as well.
Yeah, one other comment to build on what Kate's saying. We've seen from like 1,700 customers, we have this frustration on not having a holistic view on what ROI means. And so they're like these visionary buyers, they care so much about their member experience. So they're pushing for exactly what kind of utilization, adoption, how much consistent care and outreach we have from our care team. And then of course you have a lot of, companies that are trying to also prove that the spend is worth it. And because there's so many new people in the space and so many people trying to bring proprietary ROI metrics and a lot of fluff, there's a lot of doubt out there. And, one of the things I think that you have to do that's really responsible is if you're going to be a healthcare company, it doesn't matter if you're digital, virtual, first care, you need to have clinical rigor and data driven in your foundation, in your blood. And I think that that's one of the things we've tried to do now is not just trying to show what we see in our data, but to partner with our clinical teams, our data teams, and the buyers and the consultants to do joint ROI claims analysis and to figure out how to show the secret sauce between how we're bringing these ROI claims together so that people believe in the data. So I think there's just a lot of fluff in the space. There's a lot of unproven ROI. It's really challenging. And I think one of the things that we're trying to partner with our consultants and our health plans is trying to come up with a unified approach that buyers and other entities really believe in the data so that then we can continue to work together based on those foundational data points to improve.
I love that so much. You sort of talked through my previous slide, Arvind, the impact group, again, working with you and Rock Health and Mercer and others is also working in that area to figure out like, what's a buyer guide to value, to what should you be looking for? What are the table stakes criteria for assessing and vetting? And along those lines, I wanted to show everybody some new work that we're doing. Sort of benchmarking the ecosystem, asking buyers' opinions, but we also want to look at the supply side. So what are the companies out there in this ecosystem? And probably by tomorrow afternoon, and I'll send you all a note if you attended this webinar, we will have an Airtable up that is an ecosystem map. And so this is a beta version now, but we've captured you can see there's about 99 companies on here, all of which are working either directly in the virtual first space or supporting key enabling technologies. And we've looked at national scale, we've looked at the care model, therapeutic areas, et cetera. And so that will be public access on our website. And there should be a link in the chat. If you are not on this map, or you are and you didn't know about it, we'll put a link in the chat now that enables you to go in and get your company on this map. And there'll be sort of a lot more coming on this ecosystem map, but we're excited about it as another way to look at the ecosystem in a new way and really start to educate the world about what we're doing. So in closing, you guys are incredible. We could probably talk all day about this subject, and maybe we'll have another opportunity to get you all back. Please, if you're participating in this webinar, go ahead and get a hold of us. Check out our website on Dime for additional webinars coming up. Let's flip through those quickly. And again, don't hesitate to contact me. I want to hear from you. If you're doing great things, you have questions, let's start the conversation. So thank you all, and till next time.